So we're going to have 4 speakers during this session. I'm going to provide a short introduction. Then Joe Orsini is going to talk about the Newborn Screening Council that we formed and what it's doing. Matern is going to talk about how Cycozine has transformed newborn screening for Krabbe disease. And Rob Stone is going to talk about later onset Krabbe disease, how it's identified through newborn screening, how we can stratify babies by risk, and recommendations for follow-up, both including confirmation of diagnosis and then follow-up for disease presentation. So by way of background, the New York State experience with newborn screening really provided us with an amazing amount of critical information to move the field of Krabbe newborn screening forward. But in the New York State algorithms, the initial risk assessment of screen-positive babies was really too broad, and identified babies at risk who were actually not affected with Krabbe disease. The initial protocols and algorithms for follow-up of these babies were too invasive, too frequent, and as a result, compliance was poor. And there was criticism regarding placing families who really were not at risk under stress and worry that their baby had Krabbe disease. And this was a valid criticism, which we've all been working together to address. The recognition that Cycozine could be measured on newborn blood spots and the observation that Cycozine could differentiate babies with early infantile Krabbe disease has really transformed the algorithms for newborn screening. And Dieter is going to really go into detail about this. But briefly, babies with early infantile Krabbe disease screen positive on the enzyme screens, but have Cycozines over 10, can be rapidly identified, meaning within a day or 2, and referred with parental counseling if they agree for hematopoietic stem cell transplant, which is the therapy available today and in the future for other therapies. Babies with a risk for later onset Krabbe disease generally have an intermediate Cycozine between 2 and 10, can be identified and can be followed based on risk stratification, which Rob will present during his talk. Unaffected babies generally have Cycozine under 2 and will not require additional follow-up. Many newborn screening labs have incorporated Cycozine into their second tier or reflex testing, and it's our hope that all labs will be doing that as soon as possible in the future. So we've come a long way from when New York pioneered newborn screening for Krabbe disease. We've also created a newborn screening council, which Joe will tell you about. The function of that council is to assess policies and recommendations and to serve as a resource for the newborn screening labs and referring physicians to review very complex cases and determine the best path forward for those babies. Our goals are to have all newborn screening labs enable Cycozine testing with rapid turnaround, meaning 2 days or less. For each state to develop a predetermined roadmap for referral of early infantile Krabbe disease patients to transplant centers for transplants so that it's not something they have to face the first time they have a positive baby. To identify babies at risk for late onset Krabbe disease, we now know this is possible, and to stratify those babies with follow-up protocols, which again, Rob will describe and are under development, but which are less invasive and sensible based on whether the risk is in infancy or later on in life. Kristen Page and her team are working on a manuscript describing the outcomes of the first 6 babies identified in the modern era of newborn screening in the last 4 years who went to hematopoietic stem cell transplant, and she'll present that data later on today. And as a result of all of this, we feel that we're in a much stronger position to apply to the RASP and to ask to add Krabbe disease to their newborn screening panel. So now I'm going to turn the screen over to Joe, who will talk about the Newborn Screening Council. Then he will turn it over to Dieter, who will talk about Cycozine. And Dieter will turn it over to Rob, who will talk about the information about late onset Krabbe disease. So I'm going to stop sharing, and Joe hopefully is going to start sharing. Thank you. Great. Joe, you're on mute.
Can you hear me now?
Yep, we can hear you.
Okay, great. Yeah, I unmuted the line and forgot the *6 part. So, I'm going to go over just this, the Newborn Screening Council quick here, some of which is going to emphasize what Joanne had already mentioned or re-emphasize. So I think the real purpose of this council was to really continuously improve newborn screening for Krabbe disease, methods, follow-up algorithms, and really working with all the states to try to, as best we can, come up with, the most efficient algorithms that are going to identify newborns with Krabbe disease. Still up in the air about late onset versus early onset. That right now most states are looking for later onset, which is we're picking up late onset cases. So the idea really is to provide updates and improvements to that any of these that we have that they're provided to the newborn screening community. Any changes to recommended follow-up protocols that this group would come up with are all communicated. It's not necessarily going to be every group would pick up on these, but that we would all be working together to develop the recommended follow-up protocols. It's a forum to discuss difficult to diagnose cases. So if things are coming up and physicians are evaluating a child and you're looking at Cycozine, enzyme activity, and genetic genotype, there's a lot of experience that can be had and looked at, and we like to, discuss those kinds of cases. So if anybody has those and needs assistance, there's a fair number of us that are willing to help out with that. It's a platform to discuss all issues related to screening for Krabbe disease and provide any feedback to propose changes that would be out there. And then finally, all members are informed of any latest improvements. So the members include newborn screening labs and follow-up staff, people who develop the assays, people who are involved with evaluating Krabbe disease patients, diagnostic laboratory individuals, geneticists, neurologists, and transplant physicians. So it's pretty much anybody who's beginning with screening all the way to transplant physicians, and all are welcome. We have monthly meetings via Zoom, and I think one of the main messages of my talk here is that if you're interested in participating, let Joanne, myself, or Anna know, and we'll make sure you're involved with these Zoom meetings. Some updates just real quick. The NBS programs are now working on second-tier Psychosine testing. Whether it's, by that I mean we've come up with a method where Cycozine can be evaluated at varied labs, and all of the labs are getting similar results. This is done through use of Mike Gelb's dry blood spot Psychosine controls, so he has calibration curves. So each lab can has a set of these calibrators, and the calibrators are being used by all of us at this point. If there's anybody not using them and you'd like to know more about it, please let me know. But the idea really is to be able to use the information that the Mayo lab established for Psychosine testing, and kind of the levels of the reference ranges for late onset versus early onset Krabbe disease, and to be able to all of us have be able to get the same results on samples using these calibrators from Mike Gelb's lab. It's also the availability of high sensitivity Gal-C testing on leukocytes, and we're looking at that as a way to assist us in defining who's going to be in the late onset group especially, and kind of overlaps with Cycozine, as Dieter will show. And then Dieter is going to probably also talk about the availability of Cycozine testing in red cells, which is recommended for diagnostic follow-up because this matrix is a little, has less variables. So couple other things about the NBS Council. There are 2 manuscripts in preparation. We are, there's the one that Joanne talked about that talks about newborns that have been transplanted or identified through newborn screening and how they're doing via from the transplant, the treatments. The diagnosis of late onset Krabbe cases that have been picked up. There have been 3 and so far that have been later onset that have been picked up that are actually clinically showing clinical symptoms. There's a subgroup of the council working on RUSP application and a subgroup that is also working on which patients are at risk for later onset and developing the algorithms. This is what Rob is going to talk about. And then the final thing is we're ongoing consulting support for difficult cases. So that's the NBS Council. I'm going to stop sharing and then can go over to Dieter for his Cycozine talk.
Can you hear me? Can you see me? Or can you see my screen? More importantly,
Yes.
Yes,
what do you see? Do you see the presentation or do you see a PowerPoint thing?
the PowerPoint thing.
I
I know, I have the same problem.
I'm just going to turn off the other monitor and maybe it comes over then.
Yeah, that's what happened to me.
Okay, now everything is dead. And what did you do about it?
Well, I can still see it. I think that if you just put it into
You can
presenter
swap.
view.
There's a thing that says swap view.
Oh, you lost it. Yeah, you have to. So do you see yourself right now?
I see you all on the side.
Yeah, there's a
So-
thing that says swap view on the top that allows you to switch the screens. I know I had the same problem that he had because I have 2 screens that my computer goes to.
I think he's on single screen now. Just resume playing the show.
Okay.
Yeah, maybe I close it first. Sorry about that. Doesn't do it. Let me get out of PowerPoint.
Later, you can go back to previous screen and click slideshow.
It's all right. Let me see. What do you see now? Anything?
Your desktop.
Oh, that's.
Just-
And now?
I see a white screen.
Okay, maybe that's getting there.
I think you may have to have it open before you share.
Well, I did have it open.
Yeah.
Okay, we
There
got
it
it.
is.
Yay.
You have it?
We
Yeah.
have
Yes.
it.
Okay. Okay. I don't have it, but maybe now. Do you have it now? I have it. Everyone has it.
Yes.
Yes.
Yes, we're good.
Welcome. Thank you. Thanks for your patience. Okay, so Dr. Kurtzberg said I should talk about how Cycozine has transformed newborn screening, but unfortunately, I think we're still at the level where it could transform newborn screening. And I think if you heard the previous state reports, I think that is true. Also, because of it could transform, and the fact that we have more than 150 people on this who may not all be very familiar with newborn screening, I'm trying to go a little bit further back to try to explain how I get to this point. So just to level set in terms of who's screening for Krabbe disease, we heard from all the states that are currently doing it. Pennsylvania is a little bit of the crazy outlier because they have such confusing rules, and Indiana just joined. So there are 8 states now. If you look at lysosomal disorders, you have several that just screen for one condition, Pompe disease or Krabbe disease. You have then the states that screen for the 2 condition lysosomal disorders that are on the recommended uniform screening panel. And then you have some that screen for 3, 4, 5, and 6, and even 7 in Illinois. If you look at the leukodystrophies that are on the panel, so there's ALD and Krabbe disease. Because ALD is already on the recommended uniform screening panel, you can see that there are several states that screen for ALD and fewer for Krabbe disease, and fewer even that screen for ALD and Krabbe disease. But those numbers are growing if you look over time, and as you have heard. So since 2016, Mayo has been screening the Kentucky babies for Krabbe disease, Pompe, and MPS I, and then also for XALD. This is basically what you heard already, our algorithm. It has, again, since 2018, we've been screening for extrarenal leukodystrophy in addition to the 3 lysosomal disorders. So the algorithm has changed a little bit, but we're basically measuring 10 analytes for every baby, 6 lysosomal enzymes, and 4 lysophosphatidycholine in one assay from 2 blood spot punches by tandem mass spectrometry. We use CLEAR to interrogate the data that come off the instrument and basically ask CLEAR to look for any case that may be at risk for any of those 4 conditions. And if any of those is basically non-normal, then we do a second-tier test for these conditions. And if the second-tier test is abnormal, then we report it out as presumptive positive. And if the second-tier test is normal, then the report goes out as normal. So for second-tier testing for Krabbe disease, we have Cycozine, and this is a recent paper that Joe just mentioned about the attempt to ensure that the laboratories that measure Cycozine in blood spots give you the same result independent of where you sent the blood spot, so that you can compare, and we can use the same cutoffs and ranges to make the right interpretation. For MPS I, we look at dermatan and heparin and also measure keratin at the same time. So this also functions as a second-tier test for other mucopolysaccharidoses. And finally, for Pompe disease, we look at creatine and creatinine. These are actually analytes that we measure along with our acyl carnitines and amino acids and succinylacetone. So it really is not a second-tier test because you can run that with every blood spot that you run. So if you screen for Pompe and for creatine deficiency disorders, for example, you get the second-tier test built in with your screening. So what is a second-tier test, however? And I think that is important to understand. If you look at the results of what the states are doing right now. So second-tier tests are meant to be a cost-effective approach to reduce false positive results. And that is in situations where the marker that you're looking for, such as galactocerebrosidase activity, has overlap with carriers that are not affected, with people who have these pseudodeficiency or low activity variants and have not Krabbe disease, and of course, just regular babies who may have, for whatever reason, the low activity, and maybe it's just measured low. And what you do then, you take another punch from the same card, you do the more specific assays, such as Cycozine as in for Krabbe disease, and so you don't need to go back to the family and say, hey, we need another blood spot. And when the second-tier test result is normal, then you're done. You do not report a low GALG activity with a normal Cycozine. That just doesn't make any sense. Then you don't really, you certainly don't really reduce false positive results. And there are other examples that are used in newborn screening. both biochemical and also molecular, such as for cystic fibrosis. So again, the important part is that the second-tier test should overrule the first-tier test. So how does it work? At the birthplace, the sample is collected. It goes to the screening laboratory. The primary screen is done. If it's normal, everything is fine. If it is abnormal for these analytes, such as galactosaccharose, then what often is done, you ask for a repeat. And then if that is abnormal again, then you go to confirmatory testing. So again, we don't like it. And Krabbe disease, as we know, is at least infantile Krabbe disease is a time-sensitive critical condition where you should have results by the 5th day of life. So if you do have an abnormal result, you do another test on the same specimen, and if it is normal, which it usually is, then the report goes out as normal, and no one has to hear about a little bit of reduced gout activity. But if Cycozine was abnormal, then you go right to confirmatory testing, and you can tell the family that this is not a joke, this is not a hoax, this is something we have to follow up on. So we published our experience of the first year of Kentucky screening, which included the baby that was born. We had one positive, which turned out to be the true positive. We had no false positive, and to date, we're not aware of any false negative. So our finding is one case in 243,000 babies screened to date. So this is the case. The newborn screen was collected on the second day of life. It reached the Kentucky lab on the third day of life and came to us on the fourth day of life. We do an overnight incubation, as was described earlier, using an assay that we stole from Dr. Gelb and Joe Orsini, and then added our own little touch to it. And that's what we're still using for the lysosomal disorders and ALD. And then on Sunday, this kind of goes back to the issue that Indiana just mentioned, you really need to run a screening lab every day in the week. So on Sunday, we had a result where Clear said, well, this could be Krabbe disease. So we actually did repeat on the same blood spot the assay, and we initiated the second-tier test that we do, Cycozine and the 30 kb deletion. We do the 30 kb deletion because Kentucky, it was important to them that we do something molecular. So we said, okay, we'll throw that in as an immediate second-tier test, and we do sequencing if there's any risk. So on Monday then, gout was still low. Cycozine was really elevated, but the 30 kb deletion was nowhere to be found. But because Cycozine was elevated, we did report it out. We told the colleagues in Kentucky that this is an emergency. The baby has to be seen immediately. They did their best. The center that they had thought they had contracted with or an agreement with in Kentucky said, no, we won't do a transplant. And so the family, through Hunter's Hope and Facebook, etc., eventually ended up on a private plane and flew to Duke, where they arrived on Tuesday morning. So on the 7th day of life, they arrived there, and Dr. Kurtzberg and her team started the evaluation to confirm that this is Krabbe disease and to also prepare for an eventual transplant. On the 9th day of life, the diagnosis was confirmed by Dr. Wenger through enzyme activity. We received another blood spot and CSF to do Cycozine, both of which were elevated, and the genotype showed a known pathogenic mutation and a variant of uncertain significance. So in any other state that uses a genotype to decide on the results, this kid would not have had a transplant on the 24th day of life, because people would have said, well, maybe it is, maybe it's not. So Cycozine, I think, really made a significant difference in this case and allowed for timely intervention. And here's the kid at the 100-day post-transplant mark. And you heard from Kentucky earlier how the patient is doing, and probably later today from the Duke group. So listening to the presentations earlier, I put together this table. So in New York, 558 positive reports, 8 true positives. So I threw in the likely late onset cases here. The positive predictive value is 1%. So it's compared to Kentucky, not quite as good. In Missouri, again, the false positive rate is 0% in Kentucky. The 0.02% and 3%, it really doesn't sound much, but remember there are families that are part of these small percentages that are being told that your child may have Krabbe disease, and I think everyone who's participating here knows what Krabbe disease is, and that you don't really want to think about it unless you have to. So I think it's really important to improve the newborn screening and the positive predictive value. Where is Cycozine part of newborn screening at this point? In New York, it's still a little bit half-heartedly. In Missouri, it is now part of the screen. In Illinois, in Tennessee, not in New Jersey and Ohio, and in Kentucky. And yet we have these differences. So why is it? So we all do the GALC activity as the first-year test. Then in Missouri, we now do, or they get done, Cycozine and GALC, but they report both results. So if a physician receives a result that says Cycozine is normal, but GALC activity is low, what are they supposed to do with that information? Is that a presumptive positive? Or is that, well, just for your information, but the kid doesn't have the disease? Based on the follow-ups that we get from states, from Missouri clinics, it seems to me that physicians still follow up on anything which is not just normal. So you should not report Cy and GALC. You should say this is normal. This is not at risk of Krabbe disease. New York, again, we heard still primarily relying on molecular data. CLIA is helping them, which is good. But again, we've seen the data. Ohio doesn't have a second-tier test. Illinois does Cycozine and sequencing, but still, I think there's room for improvement. They're not using the second-tier test as designed. Kentucky, we heard about. Tennessee is using Cycozine, but also may still report GALC activity, which might be confusing. And then New Jersey, we heard they do GALC sequencing, but not really even as a second-tier test. It's a nice to have, and it certainly is helpful for the family and the physician, because then they don't have to get approvals to get sequencing, but it is really shouldn't be considered a second-tier test if you really just report out primarily the GALC activity. So, and all of this ends up then with additional testing, all of which costs money, all of which costs time, and all of which causes anxiety in the families. And often the physicians are stressed out too, because we always report on Friday afternoons. So who is actually using Cycozine properly? At this point, I have to say, is really just Kentucky, because everyone else still looks at, either reports the activity or relies on genotypes of uncertain significance in addition to Cycozine, but doesn't want to make a stand as to what this actually means, what they get from newborn screening. And it really isn't so hard, because if you look at the data here, this is infantile Krabbe disease Cycozine levels in blood spots, late onset Krabbe disease cases. These are cases that have genotypes that we consider pseudodeficient, and these are people or individuals who are carriers for pathogenic GALC mutations. And they pretty much overlap with the reference range, while the others are above that. So with the recent paper, many of which the speakers here are part of, we did provide a newborn screening algorithm, which starts with a low activity and then goes to Cycozine. And then comes an idea of what this means. If Cycozine is really elevated, you should have to follow up immediately, because this is most likely infantile Krabbe disease. You haven't seen any case with values greater than 10 Cycozine that didn't require intervention. If it is between 2 and 10 right now, or an intermediate level, we suspect late onset Krabbe disease. These families and babies unfortunately require follow-up, and then some of them already have received transplants. And if Cycozine is normal, the screen is negative, period. And this is things that have to be decided at the newborn screening level. I don't think it is right for the newborn screening programs to just send this out and let the physicians deal with it. They have other stuff to do. If we are professionals in newborn screening, we should take ownership of this. So for confirmatory then what we have at minimum, what we need is GALC activity in leukocytes, Cycozine in blood spots or in red blood cells. It's at this point not so important whether you get it in blood spot or red blood cells. It might be more important for follow-up and monitoring to use red blood cells because you don't have the issues of dried blood spot quality, etc. So because you can normalize then to hemoglobin. And the genotype is done. It's in the gray zone often because of the variants of uncertain significance, but I would fool myself if I would say that that we wouldn't run it anyway. So the genotype is part of the confirmatory testing. And of course, if you do a lumbar puncture and all these kind of stuff, there's additional things you do. Here you see from the Günzel paper, a graph that shows you the values again, Cycozine in blood spots, similar to what I showed you again, just in a different order. This is red blood cells, Cycozine, where we don't yet have enough numbers to build out these ranges, but we'll get there. And then here is the leukocyte enzyme assay, where we also see very good discrimination of infantile Krabbe disease from pseudodeficiency in carriers and normals, of course. There is overlap with late onset cases, and there's also a little bit of overlap with late onset to carriers and pseudodeficiency. But this assay, along with Cycozine, certainly has been very helpful to many of the physicians out there who we provided these graphs where we put the day patient values in to help them also explain to the family what is going on. So in summary, I think biochemical genetic testing, second-tier testing, such as Cycozine, is just increasing efficiency and effectiveness of newborn screening. Most patients with Krabbe disease can be diagnosed with what I just mentioned, activity in leukocytes, Cycozine concentration in blood spot or red blood cells, and a genotype. There are still questions remaining regarding the sensitivity of Cycozine and the specificity of GALC and the pathogenicity of all these variants of uncertain significance. And therefore, I think it is important that in newborn screening, we really must define what is it that we're screening for. What is the primary goal, the core condition that should be screened? And we really should look back at how SMA was added to the RUS, because here it was defined that we're looking not at anything that moves when it comes to SMA, but we're looking for SMA due to homozygous deletion of exon 7 in SMN1. So this was actually endorsed, and I think it is important. This is what we said in the first guideline paper that Dr. Kwon headed, where we said that we really need to consider what the primary goal of screening is. Again, a core condition is a disorder that should be included in every newborn screening program, and a secondary target is a disorder that can be detected as a differential diagnosis. So yes, it's a screening test. We will identify, I'm pretty sure, all infantile Krabbe disease cases. We will identify pretty much all of the late onset, but there will be a few cases that are extremely difficult to detect, and we might not identify them. And if we try, then we will have too many false positives. So it's a decision that has to be made. And again, these people said that newborn screening stakeholders and program administrators must decide if the possibility of not identifying unusual and likely rare patients with low GALC activity, GALC genotypes of uncertain significance, and normal Cycozine is acceptable to avoid false positive results. So really, this needs to be considered. So we have come a long way, certainly true. And our goals are that all newborn screening labs enable Cycozine testing with rapid turnaround time. I think that is not a problem anymore. I think all the labs that are offering it will provide you with a rapid turnaround time. But what we do with these results still is a further way to get to. That we actually use Cycozine in newborn screening to make a decision whether the result is going out as negative or presumptive positive. So hopefully next year we have come all the way and have really improved newborn screening. And with that, I would like to acknowledge all the colleagues and the colleagues in the laboratory here. that make all of this possible. Thank you.
All right, I'm gonna take over. I'm Rob Stone. I am a child neurologist at University of Rochester, part of the Newborn Screen Council, and I'm gonna be presenting on some more of the clinical follow-up guidelines that the council determined. So kind of bringing this from the newborn screening labs into the clinical realm. I will try to be relatively quick. I know that the Eastern time zone folks who are getting into lunch here. So the original follow-up guidelines came out in 2009 and were based on sort of the best information that we had at the time, which had to do with the GAL-C enzyme level. And you can see there the different cutoffs for low risk, moderate risk, and high risk. For moderate risk individuals, it was recommended that every 3-month visits be done and annual testing with all 5 of these different tests, which was an MRI scan, lumbar puncture, brainstem auditory evoked response, visual evoked potentials, and nerve conduction studies. The high risk individuals, or who was thought to be high risk, it turns out a lot of those individuals were not actually high risk, were recommended every 3-month testing, every monthly visits, and then every 3-month testing with those 5 tests in the first year, and then every 6-month testing in the second year. So as Dr. Kurtzberg already mentioned, this really led to a lot of testing in individuals that it turns out probably were not at very high risk for later onset Krabbe disease. So what we've done, we've decided, and again, this is just the information that the entire Newborn Screen Council has discussed over the course of 1 to 2 years in our meetings, is to, I'm gonna skip this slide for a second, is to update our follow-up recommendations. And really the major change, as Dr. Matern just kind of went through, is the addition of Cycozine as the major step in determining follow-up. So we have these 3 risk categories for follow-up. One is the early infantile Krabbe, where, you know, obviously, as everybody here knows, requires immediate counseling of family and referral to a transplant center. And then this new group at risk for later onset Krabbe disease, which is what I'm going to talk mostly about, where long-term follow-up and monitoring is required, but immediate referral is not indicated. And then thirdly, the unaffected group, where no follow-up is required. And I'm talking about these 3 levels of classifications really at the level of the clinician. So the person who gets the newborn screen result from the newborn lab and not at the level of the lab. Okay, so just going back 1 second to the original follow-up guidelines, you can see that we reviewed a cohort of 47 patients from the New York State database, de-identified, and saw that if we excluded those who were specifically diagnosed with early infantile Krabbe, it included 36 patients who were considered high risk and 11 patients who were considered moderate risk, and therefore you can see the amount of testing for the whole cohort over 2 years, which was 952 total tests for 47 patients over 2 years. So our new guidelines, I'm going to just start with early onset Krabbe and the unaffected quickly. So here we are presenting really what had already been published in that Kwan et al. Article that Dr. Matern had just mentioned, where we would be concerned about early onset, early infantile Krabbe disease if the GAL-C enzyme activity is in the Krabbe disease range, and the Cycozine is in the high range, which for right now I'm describing as over 10 nanomoles per liter. Although in our recommendation, we're hoping to leave room for changes in assay that might sort of change these numbers over time. So if this is the case, then the recommendation is the patient is urgently brought in, counseled, and referred to a transplant center if the parents consent. For individuals who would be considered unaffected, where the clinician would not need to do any follow-up, this is our goal, and obviously this is only possible if the newborn screen labs are sending us Cycozine values as part of their screening. But the goal is that the GAL-C leukocytes as the follow-up GAL-C enzyme activity is above the range reported in affected patients, and there's a normal blood Cycozine level, which we're calling less than 2 nanomoles per liter. Now, this gets complicated, obviously, for states that don't have Cycozine or that do automatic genotype analysis, like the New York State lab. And it's a little bit unclear, but it seems that we'll have to take that information into account, the genetic information, if we have it at the level of the clinician. So the middle category is what has caused a lot of difficulty over the years in terms of not knowing exactly how to follow these patients and trying to avoid over-testing and exposing the infants to unnecessary procedures and trying to avoid unnecessary worry on the part of the parents. So this is the trickiest category. So we would like to separate this at-risk category into 2 classifications, at high risk and at low risk for later onset Krabbe disease. And we're really focusing this on at high or low risk early in life, so within the first decade of life. So for the high-risk follow-up pathway, we're proposing that the criteria to meet sort of this pathway would be the leukocyte GAL-C enzyme activity in the Krabbe disease range. Again, we didn't define numbers on that because of changes in assay that might occur over time. For example, Dr. Matern's high sensitivity assay that he's developed. A Cycozine concentration that's in the intermediate range, and we're defining that as between 2 and less than 10 as being the intermediate range. And then really the way that we're trying to categorize between this high and low risk is based on then if those 2, if you meet 1 and 2, then genotype testing would be done if it was not done already. And we are trying to use the genotype to help differentiate between high and low risk, which is not always possible, but that's the goal. So for the high risk category, we'd want to see 2 known or likely pathogenic variants associated with young onset, like infantile Krabbe disease. And if that was the case, then we'd do a high risk follow-up. And the high risk follow-up clinically would involve clinical visits with somebody with some knowledge and expertise in Krabbe disease, usually a neurologist or geneticist. They should be followed every 2 to 3 months for the first 24 months. So as many people here know, when later onset Krabbe disease occurs early in life, so in late infancy or the 2nd year of life, it can be rather rapid in its progression. So we want frequent visits to catch that progression. And then every 6 months, between 24 months and 5 years old. And then if they reach 5 years old without any signs or symptoms, then it would be annually until adulthood. Now, all of these recommendations here are presuming asymptomatic child. So this is the screening visits. If a child becomes symptomatic, then they would be sort of out of this follow-up pathway and just be followed for their condition. So these visits should include a comprehensive history and exam. Families should be counseled on the signs and symptoms of Krabbe disease, which I've listed a lot of those here on the right of the screen. They should also be counseled that the symptoms can have an onset after an inciting event, such as febrile illness or head trauma. And if any of the above symptoms occur, and it really needs to be clear also to pediatricians to take these symptoms seriously. If any of these symptoms occur, then the patient should be brought in and urgently tested. In terms of the screening, the diagnostic testing screening for the high-risk follow-up pathway, in an effort to reduce overall testing and invasive testing based on the evidence that we have. We did a literature review, which again, the evidence is not very high quality, but the evidence that we have, MRI scan nerve conduction studies, as well as the Cycozine, should be able to detect the vast majority of pre-symptomatic or evolving symptomatic patients. And we took the lumbar puncture and the BAER out of the specifically recommended testing, but we are leaving them as possible tests if there's some confusion based on the initial studies about whether or not the child has the condition and more information is required. So for these high-risk follow-up patients, we're recommending every 4-month testing in the first year of life, and then every 6-month testing until 3 years old, and then annually after that. So still a very high amount or frequency, I should say, of testing for these patients in the first 2 years of life, but we feel that using the Cycozine as part of the criteria, we're going to reduce the number of patients in this category substantially. In terms of this low risk category or lower risk follow-up pathway. So again, the first 2 criteria are the same as the high risk follow-up pathway, but here the genotype would appear low risk or lower risk. And the most common scenario that has been seen in New York State has been variants that are a little bit more clearly associated with an older onset of disease. Now, as I think some of you have mentioned in the chat, it's still a little bit unclear exactly how to interpret genotype, and different people are working on that. And hopefully, as we get more information on that interpretation, that will make this risk assessment a little bit easier. So for people felt to be at risk, but at lower risk for later onset Krabbe, we're recommending the clinical visits with the expert be every 6 months for the first 24 months, and then annually until adulthood. We're recommending the MRI and Psychosine nerve conduction study be done at some point in the first year of life, plus or minus 6 months, so that way we can get a baseline and understand if there's any diagnostic testing suggesting that there might be evolving disease. And then based on the patient, approximately every 2 to 5 years, they should have repeat MRI scan with Cycozine, and the other tests would be considered optional based on the patient. So it's my last 2 or 3 slides here. So here again on the top of the screen for this 47 patient cohort from New York State's newborn screen database, you could see the total testing required. And then for these new guidelines, because we did have Cycozine measurements on all these patients, I was able to look at these de-identified patients and reclassify them retrospectively if we were to use these new guidelines. And you can see that 8 patients were classified in that high-risk category, 15 in the low-risk category, and then 24 patients were classified as unaffected and no follow-up required. And that was primarily based on a normal Cycozine. And you could see the numbers there that there's much less total amount of testing amongst these 47 patients. And in fact, this represents an 88% reduction in the total diagnostic testing within the first 2 years. And we believe that it would reduce the testing without having a significant number of missed patients. So these last 2 slides, I'm just showing 2 very brief examples. These are just examples from the data. These aren't the actual clinical case details. This is from the New York State database. So you could see this individual had leukocyte Gal-C enzyme activity 0.05, and the Cycozine value was 8.9. So this patient would be considered at risk for later onset Krabbe disease, and genotype testing should be done. And this individual had genotype testing. I'm not a geneticist, so I apologize if I don't quite speak of these correctly, but had 2 variants. One of the variants has been seen in a 16-year-old affected boy, and then the other variant had not been reported but was presumed to be likely pathogenic. So this patient would be triaged into the high-risk follow-up pathway for late onset Krabbe disease, and I believe this patient did end up being diagnosed with Krabbe disease. Here's my second patient example. Here, the leukocyte GAL-C enzyme activity is 0.15, still in the potentially affected range. The Cycozine value was in the intermediate range. It was not normal, but not over 10. So we would think that this person was at risk for late onset Krabbe disease, later onset. But the genotype testing, now this is the legacy nomenclature for genotype, but this specific genotype that this individual was homozygous for had been felt to be associated with juvenile or adult onset disease. It's one of the more common variants that was seen in this New York State database. And for a long time, it had just been found to be disease causing an individual with another pathogenic variant, but there recently had been one report of an individual homozygous for this mutation or this variant who had disease that came on in adulthood. So this individual would be triaged into the low risk follow-up pathway and would not need all that frequency of testing early in life.